Alrighty, thought I'd start this like a podcast. So this is chapter 48, pituitary and adrenal disorders. So I got you excited with the music. Now let's go on. So let's look at the lesson plan here. So describe the pathophysiology and medical treatment of adrenocortical insufficiency. So the cortical part of the adrenal gland, excess adrenal cortical hormones, hypopituitarism, diabetes insipidus, not diabetes mellitus. I want you to learn the difference there. Very important. And pituitary tumors. Also assist in developing nursing care plans for patients with these disorders of the adrenal and pituitary glands. So let's start with what is a disorder of the pituitary gland? Well, it's a dysfunction of the pituitary gland that can result in a problem in the gland itself or the hypothalamus that holds the pituitary. Pituitary disease is manifested by excess or deficient production and secretion of a specific hormone. These hormones can change physical appearance, emotional state, mental state, metabolism, and homeostatic mechanisms that are essential for survival. So here's that picture of the pituitary gland with just a little more definition. So you can see the stalk of the hypothalamus and the anterior pituitary hanging from there. Then you can see the target organs that the pituitary targets. This is the anterior pituitary. So the feedback system of the hypothalamus, meaning it feeds an organ and the organ feeds something back. The feedback system of the hypothalamus, pituitary, and target glands like the ACTH or adrenocorticotropic hormone, FSH, follicle stimulating hormone, growth hormone, luteinizing hormone, prolactin, the PRL, the T3 is triiodothyronine, T4 thyroxine, TSH thyroid stimulating hormone. And then you can see how then the organs have affect the body tissue. So the hormones affect the organs, and the organs affect the tissue. All right, so what is hyperpituitarism? Well, the cause is excess production of growth hormone, follicle stimulating hormone, luteinizing hormone, and adrenocorticotropic hormone. Prolactin caused by pituitary adenoma, common in young women, and may cause amenorrhea, so no period, no menorrhagia. Galactorrhea, or secretion, hyperthyroidism, Cushing's Syndrome, and I have gigantism and acromegaly just starred there only because I just wanted you to know we're going to talk about those specifically and differentially. The signs and symptoms of hyperpituitarism: visual defects and headaches at first, but can actually change physical features and soft tissue enlargement. Medical diagnosis, the way you make this diagnosis is data collection from radiology, some labs, and then there's a growth hormone suppression test. That is the key to this particular diagnosis. Medical treatment, octreotide. Now we mentioned that, sandostatin, on the table in 47.2. I need you to know about that. Also nursing care. So surgery, hypophyseectomy, we're going to be talking about that. And then if there's no surgery done, there's an altered body image. That would be a nursing diagnosis because hypopituitarism is going to cause an altered body image. Important for you to remember that. All right. So this is just, and this is in your book, it shows a progression of acromegaly of a woman over time. So you can see how the photographs have changed. So I wanted you to notice that. Man, what a change. Notice the facial features, the hands. You can't see the hands so well in the beginning, but at the end you can see they're longer. All right, now the transsphenoidal approach for hypophysectomy. So you can have a microsurgical approach. That means that what they're going to do here is they're going to go under the lip. So the patient is in semi-phallus position, so their head is higher than their heart, right? The incision is in the inner aspect of the upper lip. So just picture that. Kind of touch that up there for yourself and see where that is. And where that goes. Where does it go? Well, that goes, look at the scope. It's going way into the pituitary. And where is that? Well, that's right near the brain. In fact, the hypothalamus is part of the brain. So if you're going to go and break that sphenoid area, you are right next to the brain. So you can imagine, and look here, what I say is after the gland is removed, a piece of adipose tissue from the abdomen packs the dura mater to prevent CSF leak. So if I could point to you, you can see kind of around the brain where the cerebral spinal fluid is. And that plug needs to be put in there so there's no leak. So my next question is, what do you watch for? Well, you're going to watch for CSF leakage. And that would be in the dressing that will be put in the area where the surgery is, the lip. So watch for signs and symptoms of cerebral spinal leakage or even infection, which would be like a meningitis type of symptoms. I will talk about that later, but I might as well do it now because you're going to see like a headache, nuchal rigidity where their neck gets really stiff. So stiff neck, headache, something's going on in the brain. So here we're talking about the assessment after a hypophysectomy, neurological status and vision, their level of consciousness. So again, watch for signs of intracranial bleeding because that level of consciousness is, their LOC is key for neurological status and intracranial bleeding, because intracranial bleeding, remember, that space of the brain where the brain is in the skull, there's no room for expansion. So if you have a little bleed or a big bleed, it can totally change your neurological status. So strict I&O, inspect nasal dressing for signs of the CSF leakage. Now, interventions. What are some interventions that you're going to do? Well, the patient's going to feel anxiety. They may need hormone replacements forever, so they're anxious about that. They don't know. This is a very unusual surgery. You won't talk to very many people who've had it. They might have visual disturbances because remember, this is right near the eyeballs. They're going to have pain. Any surgery brings pain. Now, their potential for injury is there because, and again, we've talked about this, in the skull area, no room. No room for intracranial pressure. No room for bleeding. No room for sneezing because that increases the intracranial pressure. Coughing the same way. Important to remember these. Straining with the stool, important also. Potential for infection. That's the meningitis, the inflammation of the meninges. So be alert for nuchal rigidity. That's the neck, nuchal rigidity, and headache. And then the teaching, I want you to turn to page 934 because there's a teaching box there. So hypophycectomy post-op. So if the anterior pituitary is removed, you will need hormone replacements for the rest of your life. For 3 months, avoid any activities that cause straining, heavy lifting, and bending from the waist. It's important to prevent constipation because straining increases intracranial pressure, as does the sneezing and the coughing that I mentioned before. Numbness of the incision area and decreased sense of smell are temporary, because imagine where they're going. And then follow-up care is essential to monitor for any signs of tumor recurrence. So hypopituitarism. We're going to talk about hypo and hyper. So signs and symptoms of hypopituitarism, it's inadequate secretion of growth hormone. So what happens? Well, if there's inadequate secretion of growth hormone, you might see dwarfism. And dwarfism is where the maximum height of 40% below normal. It could be hereditary or caused by damage to the anterior pituitary. And it usually occurs early in life. Then we have panhypopituitarism. I believe that, I want to get you on your right page here. (9:30). So panhypopituitarism, muscle and organ wasting and disruption of digestion and metabolism. So they get what they call Simmons cachexia. Now we know the word cachexia means they're not eating, and they're going to get muscle wasting. They're going to look very thin and not very healthy. Medical diagnosis, you want to get a good history, do an exam, and some diagnostics that would be done. Medical and surgical treatment, replacement of deficient hormones. Nursing care, again, see the patient teaching box that we just talked about. They'll need replacement for the rest of their life. Be aware of signs and symptoms of inadequate or excessive hormones. Now, I put here food for thought. Because I talked about dwarfism, you've probably also heard the word midget. So what's the difference between a dwarf and a midget? Well, a dwarf, they aren't exactly proportionate. They look a little different. A midget, they are proportionate. I know they don't use midget, they use small person now. It's more politically correct, but I just wanted you, maybe you thought about it. I don't know. I thought about it. Just wanted you to know. All right. So I kind of skipped, it looks like, the gigantism. Gigantism occurs in early childhood or puberty. The long bones of the body are still growing. So what happens, you've got this growth hormone, right? In dwarfism, it occurs early in life, but in gigantism, it occurs in early childhood or puberty while the long bones of the body are still growing. So this excess growth hormone, dwarfism is a decrease. This is an excess. They're gigantic. So these long bones are still growing, and they grow really long, and their fingers get long. And that was the picture that I showed you, as well as the acromegaly. So what's the difference between gigantism and acromegaly? Well, gigantism occurs in early childhood or puberty while the long bones are still growing. And in acromegaly, It's rare, more common than gigantism though. Most patients are found to have pituitary macroadenomas. Symptoms usually occur in the 4th or 5th decade of life and affect men and women equally. Excess growth production occurs after the epiphysis, with the end of the long bones. That's the epiphysis. So the difference between gigantism and acromegaly, yeah, they're both excessive growth hormone, but one occurs early when their bones are still growing, and the other occurs after the epiphysis has stopped. So that's interesting to know. And it's important to know, too, what is the difference? Be sure you understand what's the difference between gigantism and acromegaly. Important to know. Signs and symptoms here are, and you can follow along with me in your book here, visual problems are often a result of pressure on the optic nerves. Physical features of the disease include enlargement of the hands, the feet, and paranasal and frontal sinuses. So when I talked about doing your history and your physical, you're going to look at these bones and see the difference, how they look. They're more long. And the parasinal and frontal sinuses and deformities of the spine and mandible. So the jaw look different. People with acromegaly report excessive perspiration. They have, or diaphoresis, major diaphoresis, oily skin, degeneration of the joints. So again, when you do your range of motion, you're checking that joints and any crepitus or noise that you hear in movement of the joints. Excess growth hormone impedes the activity of insulin, causing patients to have symptoms of diabetes. In addition to features that they have, patients with gigantism and acromegaly initially have increased strength, progressing rapidly to complaints of weakness and fatigue. So part of your history, you're asking them if they have these symptoms. And then as far as the diagnosis is concerned, hyperpituitarism is based on a number of data: physical assessment, the radiographs, and lab tests. That lab test would be the growth hormone. The growth hormone suppression test is the most definitive test for acromegaly. Treatment is that surgery, the transsphenoidal surgery would be your treatment, the hypophycectomy, and they might have to be on hormones after that. The somatostatin, octreotide. Sandostatin is a short-acting preparation given 8 hours by sub-Q injection. So that's on page 932. And then the hyperpituitarism is, so they're going to have the altered body image. And, so if a patient has an altered body image, we want to use our therapeutic communication, and we want to talk about what is it about how you're feeling? What is it about your forehead that makes you feel uncomfortable? So we want to use that therapeutic communication when we talk to these patients who've had an altered change in their appearance. An altered body image can be make them very self-conscious and almost withdrawn. So we want to demonstrate acceptance of them. Not that they're a freak, not that they're so different. They're just not just another patient. They're special, of course, but we don't want to make them feel different. All right. We talked about some post-op type of things that we would do that check the neurological status and the visual status. Very important, that INO that we talked about, intake and output, because that can measure specific gravity. And that's important because the patients are at risk for diabetes insipidus, which we're going to be talking about, or possibly SIADH, which we're also going to talk about later. So be sure you check their dressing for CSF leak. And again, they're at potential for injury because of that CSF leak or disruption of the packing or of that adipose tissue that was put up into their sinus area. All right, now we can get to our diabetes insipidus. So I hope you followed with me on those chapters. Somehow I guess the slides didn't reflect this, so just read through chapters 932, 933, and take note of some of the special things I talked about. All right, let's talk about diabetes insipidus. I find this majorly interesting. There's different types of diabetes insipidus. It is an excessive output of urine. There's nephrogenic DI, where there's a defect in renal tubules of the kidney because they don't respond to ADH or antidiuretic hormone, and it's inherited. Then there's neurogenic DI, which can be a result from a tumor, head trauma, infection, surgical procedure like the hypophycectomy, or sometimes metastatic tumors from the lung or breast. So then let's look at dipsogenic. That is more of a psychological disorder. It's habitual excessive water intake. Dips, like dipping, drinking the water. So it's more relative to a psychiatric disorder. So the pathophysiology of DI is massive dehydration can occur. Because you can imagine they're putting excessive amounts of urine out. So massive dehydration can occur. And that decreases the blood volume, which will lead to hypotension. See how that works? Signs and symptoms will be massive diuresis, or urine output, which leads to dehydration. So you're going to check the urine will be more concentrated, or their skin, their tissue turgor will be poor, their blood pressure is going to be low. It's characterized by hypotension. The medical diagnosis, their specific gravity is going to be low because their urine output is 4 liters. Can you imagine? 4 liters. That's twice the amount, if not more. The medical treatment is the DDAVP, which we talked about in table 47.2, which is vasopressin, so that helps decrease the urine output. Nursing care, you want to monitor their hydration. Be sure they take in enough fluids to balance their output. So that's why I and O, intake and output. Their mental status. So, fluid overload, fluid underload can affect the mental status. Confusion, level of consciousness. And then you want to check their urine specific gravity. Okay, just making sure I get everything here. Again, vasopressin too can be given as nasal spray, and it could be required for the lifetime. All right, let's move on. So now, before we move on, one more thing. I want you to notice the pharmacological capsule there on page 937, which talks about adverse effects of vasopressin administered in a nasal spray are mucous membrane ulcers, chest tightness, and upper respiratory infection. All right. If I could just recap DI for a second. So the kidneys don't respond to ADH, antidiuretic hormone. That helps prevent us from diuresing, right? Antidiuretic hormone. So here we're going to talk about, as you can see on the next slide, syndrome of inappropriate antidiuretic hormone. But the DI is, there's different types, as I mentioned, the nephrogenic, neurogenic, and dipsogenic. And the kidney does not respond to ADH. Really important to remember that. Also remember that the massive dehydration from diabetes insipidus, or DI, can lead to hypotension because they're losing so much fluid volume, intravascular volume. So the signs and symptoms of DI, and I thought this was good, diuresis, dehydration, and thirst. So that's very important to remember. Diuresis, dehydration, and thirst. Dehydration characterized by hypotension. Makes sense. Less volume. We're going to get hypotensive. Very important to remember that. And not only that, not just to remember, because when I say it's important to remember, don't just memorize. Understand why a low volume is going to drop your blood pressure. You just don't have enough cardiac output, right? To pump out. So your blood pressure is going to be low. Your heart rate will probably be weak and thready, too. It's not going to be strong because there isn't a lot to pump out for the heart. Important to understand as well as know. Knowledge is power, but it's just also important for us to remember. All right, so in the focused assessment, monitor hydration, including skin turgor, moisture of mucous membranes, pulse rate, quality, BP, and mental status. And then document everything. Document INO and daily weights and urine specific gravity. Now, maybe the doctor will order most of that. He probably will. But we want to have the knowledge to do that as well. All right, let's talk about syndrome of inappropriate antidiuretic hormone, or SAIDH. The cause is water imbalance or increased ADH. Imbalance related to an increase in ADH synthesis. Pathophysiology, plasma volume expands, giving them a high blood pressure. Signs and symptoms, dilutional hyponatremia, because they've got so much volume, but the sodium is the same. So dilutional hyponatremia, and water retention. So they're going to just keep retaining water. Medical diagnosis would be made from serum and urine electrolytes. And the osmolarity. Urine and serum osmolarity are especially useful. When measured simultaneously, urine osmolarity is much higher than that of the serum, and that indicates SIADH. So medical treatment would be hypertonic saline, because remember they're hyponatremic, so we got to give them some saline. And diuretics to get rid of excess volume. So we want a very delicate balance here of the sodium. I know usually we think, well, water follows sodium, but this isn't always the case here because we have a syndrome, a problem. We're not talking normal now. This is abnormal. So that's why it's not acting normally. We've got to give them saline and diuretics. Nursing care documents seizures and level of consciousness because of that electrolyte imbalance. Now, adrenal hypofunction or Addison's disease. So, causes of secondary adrenal insufficiency include pituitary tumors, postpartum necrosis of the pituitary, hypophycectomy, radiation therapy, pituitary or intracranial lesions, or high-dose long-term corticosteroids. So some of those can cause the hypofunction of the adrenal gland, which is Addison's disease. It's important that you understand, again, not only for now, but for NCLEX, the difference between Addison's and Cushing's, which we're going to talk about. So the cause is a destructive disease, which I mentioned, tumors, postpartum necrosis, hypophycectomy, that affect the adrenal gland, causing low cortisol and aldosterone. Pathophysiology, impaired secretion of cortisol, which results in decreased gluconeogenesis or converting the glucose, and decreased liver and muscle glycogen. And that causes hypoglycemia. Kidney filtration and stomach acid. Yeah, it affects the stomach acid. And when you read the book, you'll see that decreased supply of available glucose causing hypoglycemia. In addition, the glomerular function rate of the kidneys and gastric acid. And they're going to have nausea, vomiting, and diarrhea, so relating to the GI symptoms. Medical diagnosis is made by lab tests, the glucose and some cortisol levels. The medical treatment, replacement with glucocorticoids and mineral corticoids. So see table 47.2 for that. It talks about the treatment, those particular steroids. Nursing care is monitor weight loss, nausea and vomiting, level of consciousness. They may be pale with bronze skin and loss of body hair. This is Addison's disease. So pale, bronze skin, loss of body hair. The nursing care plan on page 942, I wanted you to turn to because there's a couple important things I want you to know there. And it says the nursing care plan for a patient with Addison's disease. So notice potential for injury related to acute adrenal insufficiency, impaired stress response, and postural hypotension. So monitor for that postural hypotension when you look at the intervention. So please follow with me in that nursing care plan and note the potential for injury related to adrenal insufficiency, stress response, and monitor for postural hypotension. If the patient's dizzy with position change, instruct them to exercise their legs, and that gets the blood pumping and equalizes the volume. And then another thing I want you to notice there on the care plan is ineffective management of condition related to lack of understanding of long-term glucocorticoid therapy. So they're going to need to wear a medical alert tag so that people know if they collapse people will be aware that maybe they might have an emergency kit on them or need an emergency kit with dexamethasone to be given because they have a low cortisol. So they might need to be given some. Okay. So now there's another situation that's in your book. It talks about, and that's in the page 940, important to know here, acute adrenal crisis, Addisonian crisis. So adrenal insufficiency at risk for adrenal crisis. So whenever you have adrenal insufficiency, you're going to be at risk for this crisis. It can be life-threatening. It's a marked decrease in adrenal hormones. Any stressor, important to remember, any factor that causes stress can initiate a crisis, such as an illness is a stressor on the body, infection is a stressor on the body, trauma, emotional or psychiatric disturbances, all overstress the body, and the body doesn't have the strength of steroids to protect it. So you need to remember that. Then some manifestations of the Addisonian crisis. So severe symptoms of mineralocorticoid and glucocorticoid deficiency. And those would be hypotension, tachycardia, dehydration, confusion, fluid and electrolyte disturbances. Treatment. So I want you to see table 48.1, which is on the next page, 941. So emergency medical care for acute adrenal crisis. Blood sample collected would be an intervention, intravenous IV infusion of normal saline with dextrose. Initial dose of hydrocortisone, Phaochromocytoma, and Phaochromocytoma is a steroid that's given only IV. It's one of those unusual steroids that you have to, the fluid and the powder is separate, and you have to actually dilute them at the minute that you're ready to use them because it loses its potential. Initial dose of the Phaochromocytoma by infusion with saline. Additional, I'm having trouble seeing today, sorry guys. Additional doses of hydrocortisone and infusion at rate of 100 milligrams every 8 hours. Then I also want you to notice the pharmacological capsule because this is really important to remember as well. So taper the steroids gradually. Now, I want to tell you a story, because this is really important to remember. Sorry. So, just like in the classroom, right? I have to stop and take a drink of water. All right. Anytime you have a patient, let's take aside just this adrenal situation. Steroids in general. Maybe you have a COPD patient. Maybe you have a patient with asthma that's on high-dose steroids. You need to taper them. You don't just stop them. Don't just stop taking them because you're going to send them into a crisis. Taper. Always taper oral steroids. You know, if anybody's ever been on a steroid dose pack, you notice the steroids are gradually tapered. One day you take 4 or 8, the next day 4, the next day 2, maybe 2 days you take 2, and then you drop. So gradual taper of steroids, and that's important when you take care of your patients at facilities. You don't just stop. Now, a 10 milligram steroid isn't going to be like a major taper because that probably is about the last dose. But we're talking someone who takes them long term. You've got to taper them. Okay, I think I made that pretty clear, huh? But it is in your book, is important to know. Oh, by the way, I actually had a story about this, that I had a patient that came in comatose. And only by family history were we able to find out that she had been on high-dose steroids for her asthma. Well, we put her back on steroids, IV, and then she woke up, and then we were able to slowly taper them off. So coma could occur besides all the other problems. So again, taper steroids. Right, so I wanted you, now we're going to go into Cushing's syndrome. So we went from adrenal, Addisons disease, right? Now we're going to talk about Cushing's syndrome. So this is what the patient looks like. And what's unique here that may not be real evident to you is their trunkal obesity. Their trunk is round, and their extremities can be very thin. So they do have a different look. All right, so hypersecretion now. We have a hypersecretion of the adrenal cortex called Cushing's syndrome. Excess amounts of steroids, especially the glucocorticoid. They may be endogenous. And what does endogenous mean? Well, that means it's within you. So that could be corticotropin secreting pituitary tumors is in the patient, and that causes an excess production of ACTH. Or exogenous means from the outside, which is prolonged administration of high doses of corticosteroids, like asthma and COPD, like I was telling you about the high doses. But high doses can cause this, low doses can lead to another issue. See how that gentle balance of things. So another pathophysiology of the Cushing's syndrome is not only truncal obesity, but a moon face, round moon face. It's important to know what these patients look like. And then diagnosis, labs, and radiology. Medical treatment depends on the cause. So it could be a medical treatment or a surgical treatment. Now again, I want you guys to remember the cause of adrenal hypersecretion or Cushing's syndrome. Exogenous cause of Cushing's syndrome is prolonged administration of high doses of corticosteroids. It's strange outside, you know. Okay, anyway, sorry, didn't mean to get off of that, but I'm right by a window. The sun's going in and out. All right, and then what these patients look like, the truncal obesity, the protein wasting of the extremities, and the moon face. Very important to remember. Then the medical treatment, like I said, it depends on the cause. So it could be administration of synthetic glucocorticoids, or the patient may have to have them withdrawn. Depends. You can read through the medical treatment and the drug therapies and the surgical therapies there. And let's get to the nursing care, because that's pretty important. The nursing care for a patient with Cushing's syndrome, they have a potential for infection related to their high serum cortisol levels. So a patient on cortisone is at risk for infection, even if they're taken orally, because of asthma or because of COPD or something other disease where they require high doses of steroids. They're at high risk for infection. So these patients need to avoid other people with infection. And in fact, on page 946, it talks about interventions potential for infection. Exposure to people with infections should be avoided because of the patient's decreased resistance to infection. Minor symptoms such as a low-grade fever, sore throat, or aches can indicate the onset of a potentially serious infection. Any symptoms indicative of a cold or other problem should be brought to the attention of the physician. So as a nurse, we have to be ultra sensitive to changes in our patient's condition. All right, here's just a picture of Addison's disease. So we have Cushing's disease, Addison's disease. Before we saw the muscle wasting, the moon face, the truncal obesity. Here in Addison's, we see the bronze pigmentation of skin, changes in body hair, hypoglycemia, postural hypotension, weight loss, adrenal crisis, the profound fatigue, dehydration, vascular collapse, low blood pressure, renal shutdown, low sodium, and low potassium. So if you're having trouble remembering the differences between these things, I am going to give you an assignment about Cushing's and Addison's. It's important that you know the difference not only for the test, but also for NCLEX. So I would really study these. Okay. Now let's talk about the nursing care of a patient with adrenal ectomy. So pre-op, we want to monitor for electrolyte imbalance and correct that electrolyte imbalance if need be. We don't want them going into surgery with a problem already. And then post-op, they need to be in the ICU for several days for several reasons. And then the vital signs need to be monitored continually because we have to observe for signs of shock, such as hypotension and thready pulse. Monitor for decreased urine output. That can be a sign because we're having the adrenal gland removed. And that can affect our urine output. So monitor for decreased urine output. And again, we want to do I&O, right, intake and output. Potential for injury related to Addisonian crisis, that hypertension. And hypotension. Resistance. Let me get to that, the Addisonian crisis again. Let's go back to that for a second. Page 940. I know it's a little confusing, kind of is bouncing back and forth, but so any factor that causes stress in the person can initiate a crisis. They get hypertensive. So we are watching for hypotension after an adrenalectomy, but we're also watching for that potential for injury in Addisonian crisis because the adrenal gland's being taken out. So you can go either way. The resistance to infection is low, so we're going to use an aseptic technique in everything, the IVs. Remember, anything from the outside to the inside of the body, we're always at risk for infection. So they have a low resistance already. So we have to be very, very careful. And then I always want you to document. Document what you've done, what occurred before you did an intervention, and then what occurred after. Did you have a successful result? All right, the next one we're going to talk about, and this is our last one of the lecture, and that is the Phaochromocytoma. In the years of my nursing, I've only seen one of these. There is a classic finding with Phaochromocytoma, and that's a hypertension of 115 millimeters of mercury or higher. And that is going to give them a pounding headache and diaphoresis. Before surgery, the surgeon attempts to normalize their vital signs with adrenergic agonists, drugs that would block the effects of catecholamines. So that catecholamine release, remember, is our epi and norepinephrine. So let's look at this grid here I've made for you on the phaochromocytoma. So it's usually a benign tumor of adrenal medulla that causes excessive catecholamine secretion. So epinephrine and norepinephrine, your fight or flight type of. Exhibit signs of hypertension, hypermetabolism, and hyperglycemia. They exhibit those signs, but the classic clinical findings would be hypertension with a diastolic of 115 or higher, severe pounding headache, and diaphoresis. The episodes are triggered by emotional distress. You see these hormones so sensitive to what we're doing. And that feedback mechanism, it's amazing that we remain in homeostasis, isn't it? Exercise, again, the episodes could be triggered by emotional distress, exercise, manipulation of the tumor, postural changes, and major trauma, including surgery. It's treated by surgical removal of the tumor, and they are at great risk for fluctuations in blood pressure and also their glucose or hypoglycemia. So they do require close monitoring. So important to remember here in the phaochromocytoma is it's a tumor, usually benign, of the adrenal medulla. It causes secretion of excessive catecholamines. Patients with phaochromocytoma exhibit episodes of severe hypertension. So you can remember that. Something to remember. Very important. So that's the end of this lecture. I hope you enjoyed it, find it interesting. Please read your book and get more information. Thank you.